Good morning, good afternoon, good evening, wherever you are. Welcome to this MDS roundtable, which is run by Blood Cancers Today. It's a true pleasure to be with you today. My name is Amer Zeidan. I'm an associate professor of medicine at Yale University. And today we will be covering a lot of the exciting developments in the field of MDS. The last couple of years have seen important approvals and some important changes to the risk stratification as well as the classification of MDS. And to debate all of these new aspects, I'm joined today by three of my colleagues. All of them are top experts in MDS. So David, in terms of the risk stratification, we touched a little bit on the molecular IPSS, but many centers don't have the capacity to look at all of these genes. Many centers will only do a subset of those genes. Some centers don't, I would say most centers don't have the capacity to do the loss of heterozygosity, for example. So how have you been using this? Do you use it selectively or do you use a partial gene set?
Normally I would think about, we have the ability to get everything, but still, regardless, we still think about IPSS-R and IPSS-M for all of our patients. Because I think the reality is that, IPSS-M does upstage a lot of patients, but most of our treatments are primarily based on the older prognostic classification. So even in, and we're going to talk a lot about luspatercept, but a lot of those patients, that were considered lower risk by IPSS-R, at least about a fourth of them were higher risk by IPSS-M. And so, but those patients still respond to luspatercept. So I think really where I incorporate it most is transplant decisions. Thinking about patients with higher risk molecular, those are patients that I'm probably going to want to send to transplant. But outside of transplant, when it comes to treatment decisions, if it's, I do kind of use both and talk to patients about both and educate them about both. But yeah, when you lack all of the mutations, I think you try to use your best judgment and use the IPSS-R and just have a discussion with patients. But I think a lot of this gets into the very nitty-gritty, but it's still a spectrum. And when you're dealing with lower risk disease, you're primarily focused on supportive therapy. When you're dealing with higher risk disease, you're more likely to be focused on transplant. And so sometimes the big picture is the better way to look at it anyways.